Thank you very much for inviting me to this webinar, and thank you, Pedro Gonzalez, for that kind introduction. My topic is controversies in venous thromboembolism in pregnancy. These are my conflicts of interest. I was co-developer of the Royal College of Obstetricians and Gynecologists guideline on thromboprophylaxis. I've decided to cover these following controversies. First of all, controversies in the diagnosis of venous thromboembolism in pregnancy, these three topics. And secondly, controversies in the management of venous thromboembolism, where I'm going to concentrate on the peripartum management and whether or not we should use thrombolysis in pregnancy. So I will come back to each of these topics in turn. Firstly, by way of introduction, I know this audience will be aware that pregnancy increases the risk of venous thromboembolism by 4 to 5-fold. Caesarean section increases this risk further. An emergency caesarean section or caesarean section in labor increases it 4-fold. These are data from the UK confidential inquiry into maternal deaths. And you can see that pulmonary embolism is the second commonest cause of death in the UK. And if you think that venous thromboembolism affects roughly 1 in 1,000 pregnant women, 1.5 in 100,000 will die in the UK from pulmonary embolism. I'm sure it's similar in Chile and in South America. And this death rate from venous thromboembolism is not improving. These arrows show when the guidelines were published in the UK, and it doesn't seem to have made much impact on deaths from thromboembolism. So you can see that the rate now is very similar to the rate 20, 30 years ago. So maybe the guidelines don't work, but you have to remember that women who are pregnant now are older, they are more obese, they have more comorbidities, and therefore probably their risk of thromboembolism is higher. When we think about when in pregnancy women are at risk of thromboembolism, this pie chart shows you the timing of death from pulmonary embolism. This bar here, the big green bar, is postpartum deaths. These are the antenatal deaths. And you can see that when looking at deaths from pulmonary embolism, the first trimester is overrepresented. However, when you look at incidence as opposed to deaths from thromboembolism, you see, as you know, postpartum is the highest risk time, but antenatally, it is the third trimester that is the greatest risk. So what this means is that if a woman is very high risk, for example, she's had a previous pulmonary embolism, then we need to use thromboprophylaxis early in pregnancy because she is at risk of a further event in the first trimester. I am sure you will be familiar with the RCOG guidelines. This is the one about preventing venous thromboembolism, and this is the one about treating it. Again, just to concentrate on when in pregnancy these thromboembolic events occur. The woman is at greatest risk immediately postpartum, and postpartum time makes up 50% of all events in pregnancy. Antenatally, it is the third trimester that is the time of greatest risk. So to come to my first controversy, diagnosis of pulmonary embolism in pregnancy. So the problem is that we worry as obstetricians and physicians that every pregnant woman who presents with breathlessness or chest pain might have a pulmonary embolism. And for every woman that we suspect the diagnosis, we will only be correct in 2 to 7% of cases. So we cannot irradiate every pregnant woman. We cannot do a CT scan on every pregnant woman. We have to rely on our history. Can we use clinical decision rules and D-dimers to rule out a pulmonary embolism in pregnancy? There are some very important recent papers on this issue, and I will discuss them with you. And the other controversy I will discuss is it better to use a CT pulmonary angiogram to diagnose or nuclear medicine VQ scans? So If we suspect a pulmonary embolism in a non-pregnant person attending an accident and emergency department, then we will be right 12% of the time. If we suspect a pulmonary embolism in a pregnant woman, we will only be right 4% of the time. In other words, we worry and we scan people, but we'll only have a positive scan in 4% of women. So these are the important papers that I want to discuss with you. Firstly, the UK paper that I was involved in, the DIPEP study. This stands for Diagnosis of Pulmonary Embolism in Pregnancy. Then there is an American study and a Dutch study. They were all published in 2018, 2019, and they all agree on one thing. The hit rate, your chances of finding a pulmonary embolism in women in whom you suspect a pulmonary embolism in pregnancy is 4 to 7%. No controversy, they all agree. So the DIPEP study, first of all, this looked and compared women with confirmed pulmonary embolism with women with suspected pulmonary embolism to try and work out whether you could predict women who were subsequently diagnosed as having a pulmonary embolism. And it looked at the value of clinical decision rules and D-dimer measurements. So this receiver operator curve shows that the sensitivity and specificity of using D-dimers to diagnose pulmonary embolism in pregnancy is very, very poor. So it's not the case that you can do a D-dimer like you can outside pregnancy and say the D-dimer is high, it's likely she's got a pulmonary embolism. Why? Because pregnancy makes your D-dimers go up. But even a negative D-dimer is not useful at ruling out a pulmonary embolism in pregnancy. What about clinical decision rules? So the physicians among you will be familiar with the Wells score, the Geneva score, and the pulmonary embolism score. And we even devised our own pregnancy-specific score. And again, none of these clinical decision rules are useful at predicting someone who actually has a pulmonary embolism in pregnancy. But these two studies, both published a couple of years ago, both suggested that a combination of a clinical decision rule plus a D-dimer could safely rule out pulmonary embolism in some pregnant women. They used different scores, and just to share this with you, this Geneva score has things like age over 65, surgery, malignancy. These are not relevant to pregnant women mostly. The other study used a special algorithm looking for signs of DVT, hemoptysis, or pulmonary embolism as the most likely diagnosis. So this is the American study, which suggested that a combination of a clinical prediction rule with a D-dimer could rule out pulmonary embolism without having to scan the woman in 12% of patients. But it took them 8 years and 11 centers to do this research. And when they looked at the number of scans that were avoided, it only avoided scanning one woman every 2 years in each center. So it's maybe not very valuable. This is the Dutch study, which used an algorithm, again, about 500 women. Again, it took them a long time to complete the study. They said in their conclusion that they were able to rule out pulmonary embolism without scanning the woman in 39%. So now it's getting interesting. Maybe this is the way we should go. They found that this algorithm they used was most efficient in the first trimester. Now that's probably because the D-dimers haven't had time to go up very much in the first trimester. They managed to avoid CT scans in 65% of women in the first trimester and 32% of women in the third trimester. But what happens if we take these strategies, these published strategies, and we look at the women in the DIPEP cohort who had PEs? Would these strategies correctly pick them up? So first of all, the Dutch study, in our women who had pulmonary embolism, some of these women, including 5 out of 12 of the women who had a PE, would have been sent home without having a scan if you had applied this strategy. And using the American strategy, 3 out of 12 women who had a PE also would have been sent home without scanning. So we don't believe that a combination of clinical decision rules and D-dimer safely rules out women with a pulmonary embolism in pregnancy. Now, one criticism of the DIPEP study is many of the women in these studies would have received low molecular weight heparin, and that affects the D-dimer test. So we looked at the real cases, and this is one of our cases in the research. She's 25, 15 weeks pregnant, BMI 36. She presents with pleuritic pain, shortness of breath at rest, no hemoptysis, no signs of DVT. Normal heart rate, normal respiratory rate, normal saturations, normal blood pressure. Her Geneva score was 5. PE was the most likely diagnosis, and her D-dimer level was 263. She would have been sent home according to these clinical decision rules and D-dimer, but she turned out to actually have a pulmonary embolism. So I'm now going to share with you another real case from my experience. This woman was 33. It was an IVF pregnancy. She had a spontaneous vaginal delivery and a postpartum hemorrhage, 2 liters. The hemorrhage was due to uterine atony and a retained placenta. She developed left-sided chest pain the first day after delivery. She was reviewed by an anaesthetist, described sharp left-sided pleuritic pain, no other symptoms, normal observations, normal examination. The pain was reproducible on palpation, and the anaesthetist thought she had musculoskeletal pain. They asked for the medical team to review her, who found the same thing and said low probability of pulmonary embolism, likely anemia or musculoskeletal pain, but send a D-dimer, which we would not have done. The D-dimer was normal. These were her blood tests, all normal. She was anemic. I saw her and I thought, well, I know the D-dimer is normal, but I don't have an explanation for this pain. This was her ECG, which is normal. What would you do now? So I wasn't happy that I had explained this woman's pain. So I did a VQ scan, and she had a small subsegmental PE in the left apex. I'm sharing this case with you to show you that it's all to do with the history. She had sudden onset pleuritic pain, and there was no clear explanation for this. She had a normal D-dimer. I ignored it, and she had a PE. So the message is that both CT scan and VQ scans are safe in pregnancy. This is the radiation to the fetus with a VQ scan and a CTPA. Both techniques give negligible radiation to the fetus. But what people worry about is subsequent cancer in the unborn child. And the risk of subsequent cancer is 0.006% per milligray, or 1 in 7,000, 1 in 17,000, sorry. The exposure with a CTPA is 0.1 of a milligray, so even less than 1 milligray. And the exposure with a VQ scan is 0.5. So yes, the fetus gets more radiation with a VQ scan than a CTPA, but both amounts are negligible. However, if you do a CTPA, you irradiate that woman's breasts, which are more vascular in pregnancy, and therefore you increase her risk of breast cancer. So particularly in women with a family history of breast cancer, I still prefer to do a VQ scan rather than a CTPA, unless I'm worried about other possible diagnoses. The other reason that I recommend a VQ scan rather than a CTPA is because you are more likely to get a non-diagnostic scan if you use CTPA, because you will get a report that says something like, cannot exclude small segmental PE, and then you have to anticoagulate her. The rate of non-diagnostic scans is much lower with VQ scanning. It is particularly the case that if the chest X-ray is normal, you've effectively done a ventilation scan. That's what a chest X-ray is. So you can then get away with just doing a perfusion scan. And that, I think, is a better diagnostic test. However, having said that, nowadays, the protocols for CT scans give less radiation than the older protocols. These are what the guideline says. The guideline says, the RCOG guideline says, compared with CTPA, VQ scanning carries a slightly increased risk of childhood cancer, but a lower risk of maternal breast cancer. In both situations, the absolute risk is small. So if you tell a woman that this scan is going to increase her baby's chance of having cancer, she will not have the scan. It's how you counsel women that is very important. I'm going to skip this slide. So diagnostic algorithm. If you suspect a pulmonary embolism based on your history and your examination, you should check for hypoxia, do an ECG, do a chest X-ray. If you're still suspicious, you should start therapeutic anticoagulation in the weight appropriate dose for pregnancy. You can Doppler her legs, because if you find a DVT, you can assume she has a pulmonary embolism. You can do a chest X-ray, and if it's normal, you can go for a VQ scan. If it's abnormal, you might wish to go for a CTPA. And in the era of COVID, nearly all these patients end up getting CTPAs because they all have COVID as well. And we have a protocol to look at COVID lung and for pulmonary embolism. You can also use echocardiogram, but even this can be normal. It doesn't exclude a pulmonary embolism, but it's very good, as I will come on to a minute, for looking at women with massive pulmonary emboli. So I've spoken about diagnosis. Now I'm going to speak about management. Several controversial issues with management. Firstly, what is the role of IVC filters? Secondly, how do you manage a woman who is therapeutically anticoagulated, who you need to deliver or who goes into labor? And can we use thrombolysis? So firstly, intrapartum management. This is guided by the obstetric anaesthetists because they have very clear rules that say that if you are on therapeutic low molecular weight heparin, then you need a 24-hour gap before they can cite a spinal or an epidural for delivery. So the problem here, when you decide what to do intrapartum, it very much depends on when that woman had her acute venous thromboembolism. If she had it at 10 weeks gestation, then you are safe to interrupt the low molecular weight heparin for delivery. If, however, she had it 3 weeks beforehand, then there's a risky time if you stop the heparin. So it's all about communicating with your anaesthetist, and you can wait 24 hours. So you omit one of the doses and then just have a conversation with the anaesthetist and consider citing an epidural or putting a spinal in for cesarean at that time. In some countries, people convert to unfractionated heparin, which has a shorter half-life, so you can stop it. We don't do that in the UK. I do not believe there is any place for using inferior vena cava filters in the context of acute pulmonary embolism. I've only ever used it in one patient who had HELP syndrome, ruptured her liver, had a massive bleeding, and then had a PE. I wasn't going to anticoagulate that woman who had ruptured her liver, so I put a filter in. But that is the only situation when I've put a filter in. Next, to come on to thrombolysis. So this is a life-saving treatment. We use it for acute coronary syndrome. We use it for stroke. We use it for pulmonary embolism. And the message I want to get across here is that pregnant women should not be denied life-saving treatments just because they're pregnant or because they've just had a cesarean section. So this is an old series now published in Obstetric Medicine, a systematic review of thrombolysis use in pregnancy. And the risk of major bleeding was exactly the same as it is outside pregnancy. The difference in pregnancy is that that major bleeding might be placental or uterine bleeding, so the obstetrician has to be aware of that risk. Fortunately, we now have these European Society of Cardiology guidelines, which state very clearly that thrombolysis or surgical embolectomy should be considered for pregnant women with high-risk PE. So high-risk PE is PE that causes shock or hypotension. So in that means that the woman's had a PE and she is hypotensive, very hypoxic. She should be given reperfusion therapy with thrombolysis, even if it's 1 hour post her cesarean section, even if she's 39 weeks pregnant. And if she's intermediate risk, so this is what we used to call submassive. So for example, a woman who has a saddle embolus, very hypoxic, but maintains her blood pressure, then what you need to do is assess her clot burden with a CTPA, do an echo to see if she has right ventricular dysfunction, and look at her biomarkers. So her biomarkers are her BNP and her troponin. Her clot burden you assess with a CTPA. If she has a high clot burden and she has a raised BNP and a raised troponin because the clot is so big that it's impairing how her right ventricle works, then you should give intravenous unfractionated heparin and consider thrombolysis. Now, the issue is, do you give that systemically, or should you give what we call catheter-directed thrombolysis? So systemic thrombolysis is available in every hospital because it's used for acute myocardial infarction. All you need is a peripheral cannula. But because you're giving it systemically, there's a higher risk of bleeding. And it might be less effective for occlusive thrombus in the pulmonary artery. Catheter-directed thrombolysis, you need a little bit of extra radiation because you have to thread the catheter into the pulmonary artery. It needs time and organization, and you need interventional radiology on site, but the risk of systemic bleeding is lower, and it might be more effective in eliminating occlusive thrombus. So to finish up and to leave time for questions, I've discussed D-dimers and clinical decision rules not having a high enough sensitivity or specificity to reliably rule out pulmonary embolism in pregnancy. I've discussed CTPA and VQ scanning. Both are safe in pregnancy. Both are associated with negligible amounts of radiation to the fetus. Thrombolysis, either systemic or catheter-directed, should not be withheld from pregnant women or postpartum women, even if they're immediately post-cesarean section. You need to ask the physician, if this woman weren't pregnant or postpartum, would you thrombolyze her? And if they say yes, you should go ahead. And lastly, and we might want to pick this up in the discussion, I haven't spoken about COVID because I'm fed up with COVID. We're all fed up with COVID. We are now in the middle of our third wave. But please, please, your patients with COVID who are pregnant need thromboprophylaxis if they're admitted to hospital or if they're immobile at home. Thank you very much for listening. This is the book that Pedro kindly mentioned, which is now in its sixth edition. And if I may take the liberty of advertising a course that I run with colleagues in London every year. This year it's in November. It's hybrid, so you can register to attend in person or virtually. And this is the website to go to register for the course. I'm now happy to take any questions. Thank you.